Wonderful. Well, welcome everyone to our Working with Newcomers presentation. My name is Rachel Hines. I'm our Director of Programs here with the Health Center Association of Nebraska, and we are incredibly excited to welcome Ms. Katherine Saaid today to present on working with newcomers and share all of her knowledge with you all. So feel free to add questions or introduce yourself in the chat. If you have technical issues, let me know in the chat and I'll try and troubleshoot. Otherwise, I'll let Katherine take it away.
All right, thank you, Rachel, and welcome everyone. I'm so excited that you guys have made time to be here today, and hopefully this information is helpful. If you have any questions, if you'd like to ask them during the middle, that's great. And then, as Rachel said, she'll be paying attention to the chat for any questions. We also have time for questions at the end. I will be asking some questions and some participation in the middle, so please be prepared to give some feedback to participate with some of our activities that we have for today. Okay, so this is a presentation on working with newcomers. That's a term that we use for refugees, immigrants, asylees, SIV, parolee status immigrants. Okay. All right, I wanted to start with just a general picture, maybe like a big picture of where all refugees may be resettled. All of these dots on the map as of 2023 are all the local resettlement agencies where the government and the national agencies will send refugees. So you can see areas of the country that are maybe super concentrated and then areas that have 0 resettlement agencies. For example, Wyoming. To this day, as far as I know, Wyoming does not have a single resettlement agency. It is something that they are aware of and are voting on. Yeah. Then the process, one of the biggest questions we have is, okay, what does it take for someone to come to the US, right? This is a very generalized process. There are nuances depending on the type of legal status that someone is applying to get into the US with. But very briefly, people whose countries, whether it's personally for their family or in general their people group or their country at large, have a situation where they need to flee from. So they flee, they fill out an application with the UN, they wait for processing entity, depending on which country that they are being assigned to, and then they go. So once they're assigned to the US, for us, for example, they're interviewed with USCIS. If they qualify, then they are assigned what we call a national resettlement agency. So for Nebraska, we have 3 actually. CWS is one of them. That's Church World Service, and Global Refuge, which they recently changed their name from LIRS. And we also have ECDC, which is Ethiopian Center is the name of it, but they help all refugees. Then refugees undergo a series of medical exams, cultural orientation before they come into the country and are assigned a local resettlement agency, such as LFS or REC, Refugee Empowerment Center. I'm not sure. I think you guys are from all over Nebraska, so I hope you've heard both of those agencies' names. They tend to be the largest. And then we also have the Asian Community and Cultural Center in Lincoln as well. And then after that, there's a whole nother process of more paperwork and more medical exams and further cultural orientation as well. So that's kind of a general process. If anyone has questions, feel free to ask. I wanted to highlight also some demographics that we've currently seen. We've seen people from Afghanistan, Burma, Myanmar, Colombia, Democratic Republic of Congo, Iraq, Somalia, South Sudan, Sudan, and Syria. Those are currently the largest groups that we see here in Nebraska, and those languages include Arabic, which is Middle Eastern, and Sudanese, primarily for us here, and then Burmese, Dinka, which is from South Sudan, French from Congo. Most of them do speak French or Swahili. We have Karen from Burma, Kurdish from Iraq, Spanish, Somali, and Swahili. Any questions so far?
You said they get assigned to the US, so do they get to choose what country they go to, or it's chosen for them?
It is chosen for them, yes. Through the UN and the other processing entities, people do get assigned, even if they know, for example, that they're being assigned to the US, even the state and city which they're resettled in is assigned by those entities and not by choice. Any other questions?
So Jenna asks in the chat, what if they already have family here? Is that prioritized?
I think they do try to work with them if they have, that's called a US tie, especially if that US tie is officially recorded on paperwork as someone who will support them and kind of help them with the transition and with learning things and housing and a bunch of other things. And so if that person is officially recorded as a US tie, they very much do try to set them up with them unless the agency in the area is over capacity and cannot take any additional clients. Okay, we'll move on then. Great questions, guys. So resettlement process, what does that mean? What does that look like, right? Because at large, you are resettling for a very long time. The amount of time it takes to feel comfortable in a different culture, in a different language, it takes a long time. But for the sake of the actual term, when we're saying resettlement time with a resettlement agency, that period is 90 days or 3 months, where you receive specialized resettlement services. Those 90 days, that is across the board for every agency in the US, and it is 90 days from your US arrival. For example, if someone arrives in Texas and it takes them time and their final resettlement state is Nebraska, that countdown starts the minute they get into the country. Or we have some clients who request to be transferred elsewhere or who move, which is very difficult and usually not recommended because then your timer from 90 days has started. And so by the time you move and you go to the new area, get a new resettlement agency, all those days have been used up, so to speak. During those 90 days, resettlement services include intake. So we meet with the families, we find out what their situation is, we help them apply for state benefits, employment and ESL services, home visits, finding housing, making sure that the children are enrolled in school. They receive some cultural orientation, and also if they would like to start the process of family reunification through some legal services, they can do that too. A lot of the supportive services, such as employment, ESL, which is English as a second language, or legal aid, those last for longer than that. A lot of resettlement agencies, based on the grants that they receive, can help people for up to 5 years of being in the US. Again, all of that is grant-based stipulations, and they do have to have a legal status under ORR, which is the Office of Refugee Resettlement. Any questions? Okay. So the refugee supportive services include, but are not limited to, some of the things we've talked about. An intake assessment, we work with clients to find what their goals are and personalize a service plan for them and for their families. We want to enroll them in some job readiness training as well and get them a job as quickly as possible, which we tend to call a survival job, or and then after that help them with a transitional job as they gain more experience and work history in the US. We have other career and job development that we do. We follow up even after they've been at their first job for a little while. And then again, other education services such as ESL, we try our best to support with transportation, interpretation, childcare, and other needs.
What would be some examples of those survival jobs and those transitional jobs?
Yes. So survival jobs, especially if clients do not come with a high English proficiency, tend to include places such as ConAgra or Tyson, a lot of agricultural um, um, organizations or companies that they work at. Walmart is another big company that hires. So basically any employer that is willing to work with someone who doesn't have, again, you have zero history in the country, zero history and work experience here in country. And usually even we might have higher skilled or professionals who had a higher education degree back home, worked in a profession, were an expert in their fields, but when they come here, a lot of that is not transferable. So initially, it's those kinds of jobs before we are able to help them with a job that is more in their field. Okay. A little bit about the process of people coming here and maybe how it affects them in terms of trauma. I want to point out that it's ongoing trauma. It's not, we've had people say, wow, aren't you so, glad that you've escaped dangerous situation and everything is better now. Well, on the one hand, yes, we do hope that life is safer and is easier and that our refugees are at a better place now that they've hopefully escaped dangerous situations. But at the same time, that doesn't stop the minute that they land in the US, right? So when we're talking about refugee trauma, typically it's divided into pre-flight, flight, and post-migration or resettlement. Trauma pre-flight is the situation before they had to flee their country, right? What unrest happened? Were they specifically targeted or country at large? So that's all pre-flight trauma. Flight is the process of fleeing. What happens during that time? For example, during the Afghan crisis, we had a lot of mothers who talked to us after the fact once we were meeting with them here once they arrived, saying that they had to wait at a camp in Qatar for some of them up to a year, some of them several months. And one of them said for a month, supplies were so few and far between that there were a few days where her kids were not able to eat. And then as a mother, having to watch her kids not have enough food as you're trying to flee for your life, that causes a lot of internal issues, affects us in many ways. So not only is the external situation difficult, but even those internal experiences as well, like being able to take care of your family and what happens as you're trying to get to a better or safer place. And then we have post-migration trauma, which means as they're resettling, what are some of the experiences that refugees have that might affect them negatively, right? We are here on this side, so our sphere of influence is that post-migration time of their new life here. So this is the area where we can provide most assistance and support. Some of the greatest difficulties are housing, work, community, and language differences. So it's a whole new different world, but your very basic needs, again, like housing, making money, being able to feed your family, those all of those things are unstable a little bit at the beginning. So that affects the 5 core adaptive systems of feeling safe, having healthy attachment, even our sense of justice, identity, role, and what it means to be alive. Even, maybe someone was very involved in their community back home and was able to give back to their community, was a respected member. And there is a sense of identity in that, of this is how I give back to my world. This is how I contribute to the world. And all of that, sometimes in a blink of an eye, is taken away, and then you start at zero in a new place, new language, new rules. which then affects you in many negative ways, right? So social determinants of health and the amount of supportive services around those really affects the mental health of refugees, right? So do they have great healthcare access and great quality? Do they have also quality education with good access to it? And what about their social and community context? Are they connecting with other people, maybe with similar experiences? Are they making friends? Or are they being isolated and not connecting with people around them, right? And then, of course, we know economic stability has a huge role to play in that as well, being able to provide for yourself and for your family and the environment in which they live. I know it's a heavy slide, heavy topic. Um, any questions on this area? Okay, ready to move on? I wanted to discuss and share a little bit about the most consistent and most maybe obvious barriers to care that we have amongst refugees. Childcare is huge. Interpretation, being able to get your language as quickly as possible, especially when you're trying to get access to healthcare. Illiteracy, how many times have we written a date and time on a card and given it to a patient saying, hey, this is your next appointment, when they can't read in English and sometimes not even in their native language. So even handing a translated written material is sometimes not helpful because they aren't able to access that information. Transportation is another huge one. And a lot of research is being done around, all of these barriers, and it's mostly access issues, prevent people from seeking the care that they need. So what do you guys think? First question of the day. What do you guys think are some of the things we can do to bridge those gaps for access to care, or those barriers to care? Any ideas? Please feel free to share, to speak up, or type in the chat.
I mean, knowing that written materials aren't accessible, I think making sure that folks know what programs are available either through little videos or translators or, literacy groups, so that folks know what they can access in their community.
Absolutely. Visuals are key.
I think I used to work with refugees where I work at the state of Nebraska, and that was many years ago, and I still work with refugees here at Midtown Health Center. I think these picture books were very helpful. These books that they have pictures, and then we were able to communicate with people in different languages. So like accessing healthcare services or other services. So we point to these pictures and kind of talk to them with, even though they don't have a lot of, but at least it's a visual. So that we were able to talk to them in a visual way. And I remember that I worked with people that were from Somalia and people with from Africa, and then the only way for us to talk to them was through these picture books. So that's how we kind of relate to them. I think they're helpful sometimes in the settings, because that's the only way that we can communicate. And a lot of them didn't know how to read and write.
Yeah, that's great. I love that you had picture books in the office. I don't think I've ever seen that. That's wonderful. The Oxford Picture Dictionary is a great resource for a lot of detailed pictures in there. And their newer versions include English to, I think, at least like 10 different languages. So it would be English to Spanish, English to Arabic, English to French, English to, I think they have Mandarin, Mongolian. There's a few different languages.
Colleen in the chat says having information for different groups or programs that the individual can connect with.
Mhm. Absolutely. Providing a information to all the things that they need to know in one place, that's huge, right? Because interpretation is already a barrier, transportation is a barrier. So being able to put as much on or in one place as possible makes information a lot more accessible. Anything else before we move on? No? Good. Okay.
1 second. I also another thing I see with refugees, there's a lot of mistrust. A lot of refugees have gone through so much that they
Mhm.
have a hard time trusting people.
Mhm.
When I work for the Department of Health and Human Services, a lot of the refugees have a tendency to go to people that English was their second language because
Mhm.
they have more trust because they say, you've been in the situation that I've been. So you started from ground zero, but there's a lot of mistrust, and sometimes we have to put in their shoes that they don't trust a lot of people. They went through a lot of stuff that very traumatic to them.
Mhm.
So they have a lot of problem trusting.
Yes. Yeah. Absolutely, especially if I don't know who you are, which we'll get into that a little bit, right? Like you said, they go to someone that either someone has recommended they know, or knowing that they've had a similar experience. So that kind of connection point, right? Absolutely. Okay. So here's just a few things which we talked a little bit about. For solutions, childcare, having child-friendly offices. There are times where we've had, let's say a mom has a lot of under school age kids, 1 or 2, husband is working, the rest of kids are in school. She has no access to childcare, but we want to make an appointment for her. But the offices, if the child doesn't have an appointment, children can't be at those appointments. We have run into that before. So then what do we tell clients or patients when the mom is seeking care and she isn't able to take the kids and has no other option? Interpretation, when someone calls an office, is there a clear process that everyone from front desk staff to healthcare professionals providing the care, does everyone know the process of getting a hold of an interpreter? Because when we do, that makes that process so much more knowledge is more accessible, even healthcare becomes more accessible and less of maybe less of a fear of I won't be understood. It will take forever to get an interpreter. What if they can't find, so to bridge some of those gaps, we need to make sure that everyone has a clear understanding of what is the process, how to get a hold of an interpreter, and to make it as smooth and as quick as possible. Illiteracy, you guys have talked about this point a lot, which I'm very proud to know that, we've got picture books, we're doing videos. That is amazing. During COVID, we had to provide some resources about how to take a COVID test, right? And so how do we go about doing that when all you get like an instruction page that is like this big and tiny font and in English only most of the time, or English and Spanish, and the majority that we work with don't speak Spanish. So creating a visual video of someone taking the test with a voiceover in all these different languages of what are the steps that you need to be able to do this at home. And transportation, again, having a good process for that or finding resources and being able to recommend that to our clients.
Teresa has a comment in the chat.
Yes.
She says, interpreters are very important, and not using family members as the interpreter is super important.
Yes, I do agree with that. I will say from personal experience as well, sometimes finding a specific dialect, especially if you're working with elders or the elderly, is very difficult if they only understand a very specific type of dialect because they haven't been exposed. For example, we speak Arabic in my family, and when my grandma goes to a clinic, we speak Sudanese Arabic specifically. We've had interpreters being brought in because, again, we say it's not best practice to use family members when my mom goes with her. That is true. But if you cannot find the exact dialect, maybe having an interpreter and a family member to help bridge that gap as a suggestion, is that acceptable? Again, you guys are the expert in the health field. Is that acceptable? Is that doable? Because we've also had the other end where the interpreter speaks a different dialect and the interpretation isn't correct. Any thoughts on that? Because they're a quiet group.
I think that's where you get into the barrier between best practices and reality.
Correct.
And Teresa's correct. Best practice is to not use a family member. Reality is that sometimes that becomes the situation.
Mm-hmm.
And if I could unmute and talk just a little more on that. It becomes very important, especially if the doctor needs to ask some questions that a family member, the patient may not want a family member to hear. But I do understand that something is better than nothing. And I like your idea of having an interpreter there, even if it's not exactly the language, and then using the member so that the family member, so that if there is something that needs to be discussed, that there's someone there to help the family member.
Mm-hmm.
In other words, if it's not great news, or if it's a question that might be a little intimidating to ask.
Yeah.
Have a professional there too to help.
Yeah, absolutely. As you said, as long as the patient is okay having the family members there. Yes, absolutely. Yeah, and some cues of does the patient seem to be understanding, or are they confused? Looking for those facial cues as well as the interpretation is happening. Yeah. Okay. When we are working with someone who comes maybe from again, like we said, different country, maybe the healthcare system is even different. What can we do on our end to empower them, to give them the knowledge that they need? Believe it or not, sometimes refugees go into an appointment, they don't know what they're there for. They received vaccines and we ask, hey, do you know what you got vaccinated for? Or what medications were you given? What were they for? And they have no idea. They just went to the doctor, they got some kind of treatment. And so being aware of giving that dignity to patients means that they understand what care they're receiving and what treatment that they're receiving. That helps, when they're coming into an office, it's such a big power distance dynamic, meaning you have all the power and they have almost none, especially because the language isn't there. So making sure that patients are well informed on the care that they are receiving, and we try our best to, and that helps develop their independence or their self-sufficiency as well when we do that. An important, I wanted to highlight the importance of personal connection, as one of you mentioned. I'm so sorry, I have the participants area minimized, so I can't always see who's speaking. But the importance of that personal connection. People are culturally more likely to go to someone, A, they've met and they know, they've seen their face, B, someone they trust has made the recommendations, or as you mentioned, they believe that they have some kind of similarity in life experience between the provider and themselves. So those community connectors are very, very important. It's not what kind of certificate do you have, or knowledge that you have, or how long have you been practicing, but it's who do I know? So it's less of that formal piece of your experience or practice of the clinic or healthcare provider, and more of who do I know? Do I know anyone there? Have I made the connection? Does anyone I know anyone there? So making sure that we are having that warm connections that help people come back and make those recommendations. There's a lot on this slide and I won't cover it in detail, but any questions? All right. Time for an activity. So if you have a pen and paper, please take it out If you don't, I'm assuming we all have smartphones, so pull up notes or something where you can type. I'll give you a couple seconds to get that together. And we'll fly through it. I'm going to set a timer as well for us on here. Okay, you will have 15 seconds. Are you guys ready? Get like some thumbs up or like yes. Okay, Rachel's nodding. Great. All right, so you have 15 seconds to complete this first part of the activity. You will see a bunch of numbers on this screen. I want you to write down in the order as you see the numbers starting at 1 to the highest number, which I believe is 20. So from 1 to 20, I want you to, in 15 seconds, write down as many numbers in order as you can see. So when you see the order from 1 to 2 to 3, go ahead and write them down. Ready, set, go. Five seconds. All right, and stop. Can you guys count how many numbers did you guys get? Do we have someone who's gotten all 20? No. What's the highest number we've got?
I see an 8, a 9, a 13,
Ooh,
a
impressive.
12, a 16.
Wow, well done. Okay, we will get to repeat this activity again. You will have another 15 seconds to see how far you can go. But this time, I'm going to give you if someone's already figured it out, well done. But there is an unspoken rule. Odds are on the left side of the page and evens are on the right side of the page. So now with that knowledge, we'll give you another 15 seconds. Ready, set, go. Okay, 5 seconds. And time. What do we have for highest numbers? Have our numbers gone up?
I see a 19,
Impressive.
a 20, a
Nice.
17.
Okay. What is that? Is anyone good with math? What percentage did we increase? Like at least what? 20, 25, 30% increase at least? I'm not very good with math, so I will not claim that I am. But yes, okay, so we got much, much higher numbers. We went from, what did we say? 11 to 16 to now 16 to 20. Yeah, great, great. And what are some thoughts on the activity? What do we think could be the point of the activity? What are some takeaways? How did it help to have someone tell you the unspoken rules?
You feel confused.
Felt confused at first. Did anyone know ahead of time that odds were on one side and evens were on the other? No.
I found that the first time I really wasn't sure what I was supposed to do. And I really didn't understand it. And so I can really see where somebody would have no idea where to even start.
Mm-hmm. Very good. See, but I knew the rules and I could have said, oh, come on, guys. That's very easy. Evens on one side, odds on the other, right? Hopefully that's not a good attitude to have.
I think that makes total sense, though, that, we expect new patients to step into our healthcare system and understand that they should see their primary care doctor and they should go to the dentist twice a year and they should do this and they should do this. And that, newcomers just they don't have that background. They don't know.
Mm-hmm. Anyone else? Final takeaways? Did it become like absolutely 100% easier after someone told you? Because we can say not everyone got up to 20. So yes, it was easier, but was it still a little bit challenging? With the time crunch. And if these numbers went up to 100, we can say it was definitely still challenging, but we stopped at 20. Yeah, very, very good insight, very good feedback. So I want to go into a time of talking about what are some cultural differences that maybe are some things that we assumed that everyone functions or thinks the same way, or as you said, from a healthcare perspective, oh, well, this is how the system works, but that's not how the system works everywhere around the world, right? So let's take a look. I just want to start by saying these are generic, broad topics that we'll be talking about. Boxes are for tools, not for people. Can we say that? Boxes are for tools and not for people. This is not to put anyone in a box. This is not a comprehensive. There are people who are a mix of both, but I just want to give you some tools that hopefully help you moving forward. Generally, when we're talking about worldviews or cultural differences, they are split into two. We have a Western worldview and an Eastern worldview. Typically, Western worldview applies to Europe, North America, I'd say probably Australia as well. And then Eastern worldview applies to the rest of the world, more or less. These are very generic, okay? It's not like, this is not precision, but these are generic, very general things that hopefully help us a little bit. So let's start with the one we know, living here, Western culture. I'll point out just a few major things or aspects of the culture. Again, this is not detailed, it's not comprehensive. So one is our value of individualization. We value the individual, or we are I-oriented. So the focus is on the unique needs of the individual or the self. Watch any commercial and it's usually, how is this product helpful for you specifically? How is this going to make your life better? We value independence. It's one of our highest values, and it's seen as a great strength. To be a successful member of a Western culture, typically, you have to be independent. You can do things on your own, right? You turn 18 or graduate college, and what do? Move out, you get your own job, you pay your own bills, you have your own life, and that means you're successful. We rely on rules or guilt. What would be usually the primary motivator is, I don't want to break this rule or get in trouble or be found guilty for X, Y, and Z. Again, self-sufficiency is a number one value, or pretty high up on the list, at least. In terms of time mindset, Western culture tends to value time as a resource, right? Time is what? Money, right? Time is a big resource. And we also are monochromatic. That means we like to see one thing at a time. We do one thing at a time. We pay to one person at a time. Great example. How many people have their microphones muted so that I'm the only one talking? Almost everybody. Because we're monochromatic. To show respect, we do one thing at a time. We focus on one thing at a time. That's how we show respect. You walk into an office, please silence your phones, because that's how we portray respect. Okay. Communication, we have, the West is a low context communicating culture, meaning if I say something, you are relying on the literal words that I'm saying to get the meaning out of what I'm trying to portray, right? It's concise, it's detailed, it's straight to the point. If I say, I am coming at this time to your house tomorrow, that is the time I'm coming to your house, because you are taking the literal words I'm saying. If let's say you guys came over to my house and I said, hey, would you like some tea? I've got pop, I've got these drinks. Would you like some? You would say, yeah, I want whatever. because you take the literal words that I'm saying, that I'm asking you if you'd like something. If you do like it, you say yes to me. So a yes is a yes and a no is a no. Okay, we'll go over the difference in a little bit. Locus of control. That means my decisions determine my destiny. The steps that I take, I can make my life turn out how I want it to be, right? Life is caused by my personal decisions. Social interactions, Western cultures, we tend to have less segregation between men and women. It's an important point for when someone who comes from a culture maybe where there's more of that gender segregation, to pay attention to who's providing their health services and if they're comfortable with that. All right, let's look at the other side. For an Eastern worldview, instead of an individualistic culture, we have a collectivistic culture. That means we are we-oriented, we put the community first, the needs of the community before myself, and we value that group unity, and which means it's very rare to see an international or a refugee going to an appointment or running errands by themselves, because we value that group. There's also that safety in numbers. And so for me to be a successful member of society here, I have to be able to put others before myself. The primary motivator would be honor or shame, meaning I will or will not do this thing because it will bring either honor on my family or shame on my family, or my people group, or whatever group that I belong to. And instead of self-sufficiency, it is acceptable to run on a more patronage system, which means those who have more resources do provide and support those who have less, and then those who have less provide high honor to those who have more. Time mindset. We view connection with people as a resource, meaning spending quality time is more important than being on time. So to show respect, I can spend so much time, even if that will make me late to my next thing, because I respect you, instead of the time itself being the sign of respect. And then polychromatic culture, meaning I can tolerate so many things happening at once. We can have high noise, it's a higher noise tolerance, interruptions are not as much of a concern or a sign of disrespect. For example, I was teaching class sometime and a client's phone rings. So the client picks up the phone, says in a more soft voice, hello, greets, hello, how are you? How's your family doing? Yes, we're doing well. I'm so sorry, I'm in the middle of class. I'll call you back later. And then hangs up. To that client, they showed respect to me as a teacher by being in a more hushed voice and ending the call quickly. But at the same time, to show respect to the other side, they did pick up, they did their normal greeting, and then said they'd get back to them later. So from that worldview, they honored both sides, the people, and it wasn't seen as disrespect. Communication, high context, meaning we look at everything in the situation to understand the actual meaning. You're not just taking my words for what they literally say, like the actual words coming out of my mouth. You look at my body language, you look at my tone of voice, my eye contact, you're looking at a bunch of different things to get the meaning of what I'm saying. So that also means if you came over to my house and I said, do you want some tea? Usually people will deny the first time or two to make sure that you actually mean it, because asking anything once is polite. Doesn't necessarily mean that I want to truly offer you what I'm offering you, or that I actually care to know how you're doing, right? It's like the, hi, how are you doing? And sometimes we don't even respond, or we just say fine and keep walking. Why? Because the first time is just polite. But so you'll notice people might ask in a single conversation more than once how you're doing, how your family's doing, because that's to show I really mean what I'm saying. It's not just words that I'm saying. Okay. Locus of control, it is an external locus of control, which means other forces outside of myself determine the direction of my life and what happens. That could be religious, it could be God, it could be the universe, it could be a situation at large, it could be government. We have some international students, for example, based on their exams that they do at the end of high school, their government places them in a specific field without choice. So the reality of life to survive, usually, it is the reality that they live in is that it is a little bit of an external locus of control. So, how does that translate to healthcare? Maybe when you're saying, okay, you're experiencing maybe some symptoms that might be because of lifestyle changes, and taking that as like your decisions determine some of your health outcomes, right? Very generic statement, depends on the situation, I know. But the way we tend to approach healthcare here is, yes, you have all these things that you need to be doing to make sure you are healthy. And that's more of an internal locus of control focus, right? So how do you finding out how to explain that in a way that includes some also external motivators as well? And then social interactions. Many Eastern cultures, again, not all, tend to have more segregations between men and women, which means when someone is seeking care, if it's a woman, typically they prefer to have a female healthcare provider, and vice versa. Any questions? I know that was a lot. No questions. So like easy peasy. Made so much sense. Any similar experiences?
I'm curious if the health centers have procedures for when a patient requests a provider of a different gender. You know, they may come in for their first appointment, see the first available provider, but based on what you had mentioned before, Katherine, I wonder if there's a procedure around that.
That's a great question, which I think I will give to Rachel.
Usually the procedure is if there's a female provider and you note it in someone's chart, you try and schedule it. If it's an emergency situation and only a male provider is available, talking with the patient first and having a female in the room is usually a
Yes.
best practice. Working labor and delivery in the hospital, sometimes if it's a sensitive issue, we'd even have the provider in the room, like behind a curtain as a male or physically separated, still there and willing to talk and speak, and then have another staff member kind of be there to like visually explain like what's happening and kind of be that go-between. Sometimes, best practice, ideally you could get the gender of the provider you want. If we don't have that, there are solutions and creative ways that we can make things happen. It would just be important to talk ahead of time and let the patient know what's going on.
I'm curious, could you speak to how the gender differences would relate to children? So for example, if mom is bringing her son in to see a provider, is it going to a female provider because that's who mom feels comfortable with? Or, but then that's a female provider doing an exam on a young boy, or would the father be present too? Like what are some of the differences there?
Yeah, from my experience, typically when it's children, there's less of a less of a preference there. It's more when it comes to sensitive issues between that a female would prefer to have a female provider, and vice versa. But when it comes to children, I haven't seen it as an issue unless Rachel has seen. No. Great questions. Any others? Okay. I wanted to provide I've only covered Omaha and Lincoln for English language services, so like ESL or ELL, places that provide English language instruction. There's a list of them here, and I'll give a copy of this to Rachel as well, and she's got it recorded. There are places even like Lexington, Grand Island, a few other places do have as well. I just did not have access to that comprehensive list, but these are major providers. They're not the only ones in Omaha and Lincoln, but they're the main ones that I'm aware of. Usually the reason for joining an English class we're talking in the context of refugee and their resettlement, that it's required for a program enrollment such as ADC, Aid to Dependent Children, RCA, Refugee Cash Assistant, or Matching Grant, which is a federal program that a refugee might be a part of. For the most part, refugees coming through resettlement agencies typically for Nebraska are involved in one of those three. When they first arrive, when they first arrive, it could be its employee provided class that the employer is willing to pay during lunchtime or something like that if their employees go to attend an English class, or it could be voluntary. It's no longer required for anything, but they would still like to be a part of the English classes. Typical process is that a client is referred to an English class, usually through a form or an email with one of the organizations, and then they're assessed and placed. You might have to fill out some registration forms as well. And then enrollment is sent to their teacher. Any question on English? One of the primary things that most refugees who've been here for a long time, we did kind of some, I don't know that we can really call it interviewing, but we were preparing for a class that we were developing. And we met with a few people that ranged anywhere from being in the US to 1 year to like 20 years. I said, what is the single most important thing for a refugee to succeed in terms of resource? And almost every single person said, learning the language. So this is huge. We cannot underestimate how much of a precursor to successful resettlement that learning the language is. No questions? Okay. A few tips for working with newcomers. Make sure that you get your hands on as much training as you can to help hopefully give a new perspective or new resources or tools for you. For example, if you're volunteering anyone, there are program-specific trainings available. Switchboard is another great one. They specifically target refugee mental health, and they have a lot of resettlement experts as well. A lot of their webinars are for free, so highly, highly recommend that you register for some of those. They also have some pre-recorded videos you can go through their library or archive. And then just being welcoming and accepting. So that means having a friendly face. We smile, we greet people. As I said, keep cultural gender segregation in mind. Sometimes people, depending on where they're from or the religion that they practice, they don't want to physically shake hands with the opposite sex. So just keep that in mind. And then showing equal dignity and respect. We want to make sure that we're paying attention to sensory bias, meaning that, for example, if someone calls and you hear an accent in English, there are subconscious things sometimes that happen where it's like, oh, we assume the person doesn't know the system. We might assume the person might not have higher education. There are some assumptions that happen with that. Speaking from my personal experience, both my parents have higher education degrees, but sometimes the minute someone hears an accent, they are treated a little differently, where either they're not given as much time or asked as many detailed questions, or dismissed or not given the same quality care as, say, for example, I make the phone call or I go into the doctor's appointment with them. So sometimes you will see in a lot of refugee families, there's a younger person that will come with maybe more English proficiency, or sometimes just a more American accent because they grew up, because they're trying to make sure that their family is being well taken care of, because they've seen some of those discrepancies in the provision of care, unfortunately. So pay attention to those, whether it's how someone is dressed or accents, what you're hearing, what you're seeing. Pay attention to that, and make sure that you're challenging, if you have any preconceived ideas, that you challenge. Meet people where they are, ask questions, and give that dignity and respect equally to everybody. And then good relationships, asking about people's families, being open about learning from culture. Again, questions have to be asked more than once to be genuine, because we are looking at that higher context of your tone of voice, your body language, and did you ask more than once, or was this, I'm just trying to be polite, but I don't really care about what's happening. And then storytelling is key. I want to say this is really important, not just in relationship building, like when you're out and about in your life, if you're building relationships with a neighbor that's a refugee, or if you're in the office and you are trying to find some symptoms and to make a diagnosis. Sometimes when you say, oh, how are you feeling? Or do you have this symptom? Do you have this symptom? And sometimes you'll get no. And then when you ask, maybe from a more story-centric perspective of, hey, tell me how the last few weeks have been. Have you been able to do your normal, daily activities, or if there's a holiday, asking how sometimes seemingly unrelated things, when you're asking them to share story rather than identify a specific symptom, you'll be surprised what symptoms come up as they're sharing those things of how they're doing, how their kids are doing in school. They might say, oh yeah, I usually walk my kids to school, but lately I haven't been able to because of XYZ. Whereas if you had just asked about the symptoms, you might have gotten no for an answer. So those are things that we've seen in working with refugees. Any questions here? Sorry, I know I'm flying through this.
I just had one from Colleen here in the chat. She said that she's been told that in some cultures, people are uncomfortable with eye contact, and is that something we should pay attention to?
Yes, so great question. Eye contact in different cultures means different things. So for us, most Western cultures, we can say that's a sign of respect. That's a sign that you're paying attention to me, to what I'm saying, that you're actually tracking, right? But in most Eastern cultures, avoiding eye contact is actually a sign of respect. If I looked someone that I highly respect has either a higher position or much older than I am, if I look them in the eye, that's sometimes seen as defiance, saying I am your equal, so I will look you in the eye. Whereas what I'm supposed to be portraying is I am below you and I'm giving you honor. So as I'm speaking to you, I might not be giving you eye contact as a sign of respect. So yes, sometimes that is true depending on who you're working with. So that's when we need to rely on some other cues. Having that high context of what's their tone of voice, what's their body language, are they fidgeting, are they able to respond in our tracking with questions even if they're not giving me eye contact. So we have to kind of pay attention to different cues than what we're normally used to. Any other questions? No. Okay. I was gonna do role play. We do not have time for it, but I'm just gonna quickly kind of sum it up. So if you were in a situation in a different country where you didn't understand the language and you remember being told that you need to call to make an appointment, the first thing you're greeted with is a phone tree in a language that you do not understand. How on earth do you even take steps to be self-sufficient to make your own phone calls when the very first thing you're greeted with is not a person, it's a robot speaking to you in a language that you don't understand? So just kind of being mindful of how our systems works. And I know that some of those things are outside of our control, but just something to be aware of that might be a big barrier for self-sufficiency for patients. Oh, it's still gonna go. Okay. These are some areas, ways that you can be involved in the community if you would like, by donations, whether they're in-kind donations or monetary donations. And other than that, any final questions? I know we're right on time, so it's a little tight, but any questions? No questions. All right. Well, if you think of any questions later, feel free to contact me. I know Rachel has my contact information if there's anything you guys want to follow up on or you know, I know questions come sometimes 2 hours later. It's like, I should have asked that question. So if that's the case, you'll have my contact information. Thank you, Rachel, so much for setting this up. And thank you, everyone, for your participation and the great insight that you guys have. I just want to really, really, truly thank you. I know the people who showed up to training, you care about your patients, you care that they are treated well, that they receive good services. So I really want to say thank you so much for what you do.